So you're hoping that this process will generate a hypothesis for you.
And then that's where our PDSA cycle will come in after we have a hypothesis. That's when we act on it.
But what made you think of getting into the whole concept in the first place? Why did you what do you think of handover as a topic that you want to tackle in the first place? What sort of made you think that this is something interesting for us, or we see a problem with it? Because if there's no problem.
Yeah. Well, I think we're all key players in this, like we're key players in the issue, and we see it every day.
What's the issue? That's
So,
what I'm trying to get at.
We think, well, I guess, yeah. I mean, you could say handover, we think that handover could be better, or
More efficient.
more,
or
or
thorough.
just
And more efficient and like.
better in the sense of like, what are the aspects? Like, you can say more efficient, you can say more time, you can say all these things. That's what we're hoping. Those themes are the things that we're hoping to evoke from the qualitative analysis, rather than seeing those things off the bat and then maybe not getting ideas from everyone. By leaving it open-ended, we almost, like, there's more potential for things that maybe personally I wouldn't have thought of. Or,
I love the process, because
Yeah.
I don't like people taking things for granted or as dogma. You know, we inherit the system and we just carry on with it for 4 years, and off you go, and the new generation comes and uses the same system. So I love that
Yeah.
you want to challenge it along the same lines of what the other colleagues were asking. Why do we make an assumption that this system is archaic and doesn't work? I mean, if your hypothesis is to say, well, this kind of handover thing is annoying, it is inefficient, and the inefficiency is because of 1, 2, 3, 4. And let's see if we can mitigate those factors, right? Have you looked at the literature to see, or did a survey across other centers to see what their process is like?
yeah.
Or is that important at all?
Yeah, I think that would be a good idea too, because I think we all just we all had some experience like training in different centers of like using different models of handover and having things that we like about it and things that we don't like about it, and I think adding that sort of like cross-sectional study to like benefits and limitations of handover, I think would be really valuable information for this as well. I think, and like correct me if I'm wrong, that like what we were like getting at is that we don't necessarily have like a hypothesis of like these are the things about handover that makes it like occasionally challenging or occasionally frustrating. But I think we all experience that handover can be occasionally challenging and occasionally frustrating. And I think the idea of like getting those like themes and like building a hypothesis based on like the qualitative studies, but then the cross-sectional study too, would be like, okay, so we have the sense that it's like inefficient and occasionally challenging, but we think that now we can say like, now our hypothesis is that it's inefficient and challenging because there tends to be too many interruptions, and then you can like go from there. It tends to be inefficient and challenging because people haven't finished all of their work from the day, and so they don't have all of the answers. And then I think then you can like build like sub-hypotheses from that. But you use that sort of like handover is inefficient and challenging, and then use that as sort of like a jumping off point.
But as for where we got the main topic, Celia gave it to us. We didn't actually think of it.
Thank you, Laura. It's my fault.
It actually is one of the best things you can think of, and it will make life for a lot of residents easier in the future years.
Yeah.
So we'll have to move on, but just before, sorry, I won't give you necessarily an opportunity to answer, but when you're designing things like, I know you were hoping to generate your hypothesis from focus groups, but going along with the fact that you hypothesized that paging interruptions were going to be an issue, it's very important to, when you're defining an intervention, to think about the variables that would be important. So you highlighted you wanted a 30-minute sign-over time, but I didn't really hear anything about, well, if there's 10 kids on service versus 30, that's going to impact your sign-over time. So a time per patient might have been a better variable. I think with your approach, you're going to struggle with the definition of urgent, because the definition of urgent was being driven solely by the team, not by the callers, and whoever's making the call also has a stake in that. So defining your stakeholders would be important. Staff turnover and staff training are important. There's a lot of, as you know, shifts change over all the time. So making sure that that intervention is implemented, even in a week time span, is going to be challenging. So the communication part and the implementation part is going to be key. And then thinking also in terms of, picking up on your point in terms of there's going to be difficulties the moment there's differences between groups and between wards and between trees. Those are all going to impact how successful your plan is. So just always kind of think about all of the variables you might want to tackle. Thank you very much.
We're very excited.
All right.
Hold on X.
Karen is putting her skate in. So that's group number 2.
Two. Okay.
So our question was formally, is there evidence that mandatory scholarly projects later impact academic success or career choices? And the decision we made was based on limitless money and the assumption that I think is safe that our program directors meet biannually across the country and keep track of how their students are doing, and that information would be available to us without any problems.
So the first thing we had to define was what is academic success and what is career choices. And we went through a large number of options before deciding that our primary outcome would be for academic success would be academic appointments within a university. And then secondary outcomes would include publications since the completion of residency.
Whether or not they went on to do an MPH or MSc or
further
PhD.
degrees, and then what they scored actually on their Royal College exam, as well as looking at career choices, so if they went into a subspecialty versus Gen Peds, and if they went to work at a teaching site. And sort of, I guess, this was a roundabout way to tell you that we are looking at pediatric residents across all sites in Canada, so that's our population. Our intervention is looking at years in which scholarly projects were mandatory compared to when they were not mandatory. So we're looking at a time period from 2005 to people graduating residency in 2020, and then depending on when each school made it mandatory, that's our cut point between the two groups. And then, like I mentioned, our main outcome is academic appointments plus the extra.
So then, of course, like any study, we also wanted to collect some other information. So that would include things like age and sex, whether or not people had a master's or PhD before going into medicine, because obviously that has implications and certain assumptions. Where they worked and where they did their medical school, as well as their residency training, as well as the city of their high school. We initially were talking about, well, should we look at where they did undergrad and whatnot, but we do think often people return to where they are from in some ways, or that might impact whether someone wants an academic. If they want to go to Toronto, then they might need that, maybe not too. So that was one of our measures, as well as what the job market was. And this one was one that we actually found the most challenging, really, as to how we would measure, because one, what the job market is on paper and what's said there are jobs isn't always an accurate assessment. Two, even when there aren't jobs, if you want someone and they're good, you make it possible for them to come, or they go and do additional training, which they might have done, so that they can have the job. So that was one piece that we're still arguably would be figuring out and deciding how best to measure, as well as do you say, well, how many residency spots are there or fellowship spots? But even that is kind of a delayed response, and some places continue to train even if they're not hiring. So that was one piece that I'd say overall we probably, if we were to actually follow through on the study, we would need to go through the literature and really kind of figure out what's a good measure of. Beyond that too, the question then became, so both of our main outcomes being academic appointment, as well as if they're working at a teaching hospital or not, when those were yes or no type questions, but do you say, did they ever work at a teaching hospital and then maybe decide to go and work in the community, or what would be our role there? And we felt that if they ever had, that counted as, it was really a binary yes or no. So did they might choose to do something else later, or they might have year 4 or 5 later gone and done that counted as a yes, which is nice in the sense of when we would be doing our analysis, it would be quite a binary outcome. The other question became, if someone's in 2005, started residency, that's a lot more time to produce more publications, just like that's more time to maybe decide to go into an academic and whatnot. So we were trying to decide whether or not we would want to do a straight binary yes/no type scenario, or more like almost a survival length of not leading to death, but acknowledging that if someone is
Academic appointment.
which is kind of like stress. But ultimately, because of the timeline and because of what we're doing, that would be reasonable, because if someone is graduated in 2018, they're gonna have a lot less time to maybe build up, and so there would be some room for some interesting sub-analysis in this, too. And then, do you wanna talk about the non-mandatory versus mandatory?
Yeah, just to follow up on that point, we felt that if we had like set a cutoff like 5 years after completion of residency or something like that, we'd be throwing away a lot of data from people who had graduated in 2005 and were all of a sudden out of our study in 2010, despite the fact that we had years of follow-up, which was one of the reasons why we wanted to do the survival analysis. And then in terms of our intervention, we really did classify like mandatory versus non-mandatory scholarly project, because we felt that that was maybe a more interesting question than whether people had completed a scholarly project in years where it wasn't mandatory. We felt those people would have been self-selected to go on to academic appointments or have more publications anyways. And so that really the intervention that we wanted to look at was whether creating a mandatory one for all residents actually changed outcomes for really those people who wouldn't have completed them before, but we're going to look overall at the implementation of that kind of program change.
And we sort of had a hard time figuring out how you would ask someone, like in our cohort, if it wasn't mandatory, would you have done a project? Just because that option isn't there for us.
As well as, because this is in pediatrics, it's a little different than if it was across the board, because certain programs allow for and build in a year for research, like it's a very different if you're in surgery and whatnot. So we felt that it was reasonable to kind of sub-focus, but in turn also what that would look like moving forward would be quite different in a pediatric type setting than some of the other medical disciplines. Though if we were not able to have a large enough sample size, it would be a really reasonable thing to expand out to include other cohorts and other specialties within the Canadian context. But that said, when we did our alphas and our betas, beta 0.2, alpha looking at about 5%, and we thought an effect size of, if there was a 10% increase in our academic point of being appointed to universities, that would be, to us, a measurable change. I think we came up with something like 387 people per arm, which would definitely be doable in the timeline that we were looking at, as well as would then allow to, if we wanted to do any sub-analysis work, to likely have the numbers we would need, though we hadn't actually checked that, in the sense of the years before it was mandatory, comparing people who did and didn't do research. I mean, there might be some interesting other pieces to the study, but ultimately the question asked us, academic success as well as career choice, and academic success for us was eventually becoming part of an academic being appointed, which we didn't mention earlier, but to get that information every year universities print who is appointed with them, and so we would just, because of the numbers and because of what we're looking for, we would just do all of the medical schools in the country and see who is and who isn't, just because working in Winnipeg doesn't mean that you might not also be appointed to U of T, and I don't think that can happen, so we wanted to make sure we accounted for everyone there. Other points of interest that would be, that we were talking about too, is this idea of rural versus community versus not, and discussing how you look at that, and is that a good measure of the different types of career choice, arguably yes, but depending on, I trained out east and rural New Brunswick and Nova Scotia is very different than rural Ontario versus like rural Manitoba versus the north, so while we thought it was an interesting point of study, it wasn't the point of our research. So ultimately,
One of the things we did talk a lot about also was our secondary outcome of board exam marks, because there was a conversation about whether the point of the scholarly project was just to fill in that scholarship piece on CanMed roles, or whether it was also to influence overall academic performance. And we thought that one way of looking at that would be to look at people's graduation board exam marks with and without the scholarly project, as well as to look at any negative effects that creating extra work for residents would have.
and otherwise, we welcome any questions or suggestions on our agenda.
So questions for you?
Good job, guys. That's an interesting approach. Did you guys, and maybe I missed this, but would there be any way to look at kind of the trend of, especially within the subspecialties, as we've heard that things are becoming much more academic?
Yeah, we had a lot.
So like
that's
looking
a lot
at
more
2005 versus 2015,
Our like
that's
job
10 years.
market
Yeah.
discussion focused a lot on how all of these academic appointees have been coming in and telling us how they had to do extra work to get their academic appointments. And so we didn't come up really with an answer on how to compare
No,
like
it'd be
these
really
to
hard.
another. But I think we were expecting to see an increased number even but there could be a difference, like a larger difference in maybe in a subgroup analysis of those who have academic appointments and those who don't in terms of number of extra degrees pre-mandatory project to post, which is not necessarily a result of the mandatory project.
And I wonder if like your 2005 data would look very different from like your more recent year data too.
Right, yeah, there's probably, we need to adjust for that confounder of like the job market pushes people to do certain
Yeah.
things as well as what a certain change in the program.
And I do feel like ideally, if we have the funds as well as the time, you could add another component of a survey that you send out and or you call and ask, and it'd be short, and then, because we'd be able to get so much of the information without interacting and asking the people, it could really be a one-pager of like, did you do this? Yes, no? Did you feel it was essential for you to have a job? Were you, like, there's those kinds of questions I think you could definitely fill in and build in, it would be super neat to see.
And there are a lot of like the like the CMA and like Docs Manitoba and stuff like that do a lot of those kind of surveys, so
So
you
like
can
linking
probably
in with-
farm some of your data from
And I think
those.
most programs that you graduate from have some sort of grad survey follow-up
Mhm.
for their graduates.
That was good. Thank you. When you were talking about your hypothesis definition, you were very elaborate, encompassing, and meticulous, and I like that. That's very important so that you can focus on the rest of your project successfully. I don't have any questions in that regard. I just have a comment, and we have time, so you're allowed to answer to it, not like
Question.
You talked about publications, and you talked about the projects themselves, but I didn't think I heard talking about the impact of the research. Because, yeah, I mean, if you look at journals, and if you look at forums where people publish, there's tens of thousands of things up there. I look at a lot of things, and I think one has to be very careful with deciding, are you going to waste your 8 hours of studying a day reading things that truly are not going to be useful to you, or you're going to make those 8 hours count towards something that you truly think is going to enhance your knowledge and enhance your ability to provide care. So I think it's important to think about how to address the impact of the research. That you won't be able to ask that question directly of the people on the questionnaire, but there are tools that would allow you to look at me, for example, and say, I only had 43 publications in
Like
public.
how many people have read
So there are
Or
tools.
like the
Exactly.
citations.
So then if you look at, then if you use specific software tools and also specific evaluation tools, it might tell you that this person has 400 publications, which were all case reports, and it won't give them a damn thing. But this person has 40 publications, but that program or that tool will allow you to say that, geez, look at what this has done, right? Because you could publish a paper every 3 to 4 years, but that's because the work you do needs that much time, right? So the type of work you do impacts the number of publications you produce. And I still think that we have to be very careful with looking at the quality of the engagement in academics. We don't do it just because we want to do it, or because I want people to say that I'm an academic clinician. That's not the reason, right? So at the end of the day, I don't think anybody who's gone to medical school want to waste their time doing esoteric things or things that are useless to their patients, in the country. So I think we have to think about how do we analyze the data once we get it, right? So I think it's okay. What you guys have done is beautiful. But when you get the data as part of the analysis, we're going to think about the really little things statistically. And one of the important points that colleague mentioned is, can we look at differences in the trend based on, let's say, blocks of years, 2005, 2010, 2010, 2015, 2020, something like that, just to look at, see there has been a graded change in our attitude towards this. The final point I was going to ask about is, how do you propose sending the questionnaires out?
So I think there's a number of ways you could do it. You could just do so you have their name, you know where they were located based on CPS, or otherwise you just send it in that way. There are other surveys though that are sent out and often filled out by like the Canadian Pediatric Surveillance Organization and those kinds of things, and it could be something that you maybe add on as part of that. Or when you're sending out their membership, yearly membership, you coordinate with CPS to send it out that way. So when they send in their dues, or they, though I know a lot of it's online, you could go online and check in with a quick little thank you of sorts. The other day I was telling these guys about a good friend of mine who did a project where she literally just taped Toonies onto all of her surgeries that went to the physicians in all of the East Coast, and they had more than 80% return, which like never happens at random. So just the simple act of doing that would be a big use of it. But I think in today's world you could do online ones as well, with just a code and have someone sign in quickly. And maybe it takes $5 or $10 off their CPS dues, and now we learned something interesting and they've saved a bit of money here. I don't know.
Can you do a combination of all the above?
Sure. Yeah, without question. I mean, surveys are hard to get back sometimes, but I think if you're asking about a reasonable question that they see value to, they might be more likely to respond.
Thank you.
So we're gonna have to move on again, so I'll just make a comment.
Sure.
So the, overall, I think you did a very good job of highlighting a number of things that would be interesting in the analysis. However, I think sometimes there can be over-inclusiveness sometimes, which will complicate analysis. So
Yeah, this
I
session.
think, you know, it's very good to map out all of the potential variables, but then paring them down into something that you can make sense of is also part of the research exercise. So just something to think about. All right, so thank you. Are we keeping the number sequence here? Well, the number 3.
That's us?
Yep.
Okay. So our question was about whether different types of like holding a child leads to more dropping of the child. So we had a lot of difficulty with addressing this, so we talked about a lot of different study designs because there's a lot of like complicated things with this. Like first of all, how do you define different types of hold? So like, do you define it as like a 2-hand hold or 1-hand hold, or do you find like actual like, okay, holding like this, piggyback hold like on the shoulders, and then like how many of those do you go into, and how do you ask parents about that? And so we talked about first like even just doing like cross-sectional survey, but we thought that that might be difficult because then you're basically like, you have to ask like, have you dropped your child? Like on the phone, which is a difficult thing to like ask parents and then be like, okay, well if you drop them, like how are you holding them at the time that you drop them? So how do you address that without being accusatory and getting like legitimate answers from parents and things like that? So we didn't think that a telephone survey would work very well in terms of cross-sectional design. So then we tried to like think of other designs. You obviously can't do an RCT because you can't just like tell parents how to hold their children and then follow them. So then we talked about like case control versus cohort, where like case control would be like anyone who has been dropped. Then you go back and look at like the exposure, like how they were holding them. But we thought that we kind of went back and forth between case control and cohort. But we thought maybe the case control wouldn't fully capture the data that on the question we're trying to answer, because then you would miss all the people who didn't drop their children, right? And so then you would be missing out on like those holds and like what like the ones that are safer and are not causing drops. So I think we ended up kind of focusing in more on a cohort study and talked about like a few different ways of doing that, and we thought like to get the best kind of sample size rather than in a case control where you just look at people who have actually been dropped, we thought we'd look at like everyone who came into the ER within our age range and just ask if they're willing to like talk about like basically like a survey but in person, so that you can more easily define like handholds and things than you can on the phone, and describe them to parents and get a better sense of like actually how they're holding their child most of the time. So we would enroll kind of anyone coming through the ER regardless of what they're coming in for, in our age range of 0 to 2 years old, because we thought that was kind of highest risk for having a child being dropped, because those are the ages that are actually being carried around. Obviously like younger, like 0 to 1 is probably being carried more than 1 to 2, but we thought 1 to 2 was still like a low enough age range that they could potentially be being carried and dropped. But we do recognize that they're probably being dropped for like different reasons, like whether they're moving around versus like 3-month-old who you're very careful with. So you'd have to have like different analyses for those, but that was our age we decided on. And coming in through the ER, and then we'd ask if they'd be willing to participate in this survey about dropping. And so the survey would include lots of different questions, including like the type of hold. So we had a lot of trouble kind of defining like different types of holds, as I said. So we do like a 2-handed hold versus 1-handed hold, and or do we actually like specify different types of holds, and then how many do you have? So we thought we would have like pictures of the different types of holds to like help parents. So whether it be like this hold versus this hold, we didn't come up on exactly, we'd have to go a little bit more in detail to see which ones we want to include. But those were the ones we kind of talked about, as well as like once your child gets older, often people do like piggyback hold or like on the shoulders, and like our children falling or being dropped from that. And then there's also other things we wanted to ask kind of to get at those confounders or differences in ages. So as well as other things that could be affecting the rate of dropping versus just the hold itself. So for example, like who was holding the child, like age of that person. So if you have like a 10-year-old holding your baby versus like someone who's like 30 and has taken care of a lot of children. So age of the person, they're kind of, we thought maybe important to be like their relationship to the child, because again, like kind of the idea being that their parent might not drop them as likely as someone who's like just visiting and holding the child and maybe doesn't have a lot of experience with holding children. And then whether or not they're standing or sitting, walking, like what they're doing at the time of holding the child. And also, like I said, like the age of the child. So yeah, we'd ask this like as they come through the ER. Again, we'd have to like kind of, again, we'll have the problem with how we question the parents, so that it doesn't seem like accusatory and they feel like they're able to say if their child has been dropped before in a kind of non-accusatory way. And then in terms of analysis, we wanted to kind of compare the proportion of children who have been dropped versus not dropped in each handhold, depending on how many we eventually decide on. And then in order to do that, we compare like the number of dropped versus not dropped in the different groups. And so when we looked at the tables, we assumed like an alpha of 0.05 and beta of 0.2, and that came up with a sample size of 539 per group. And I'm not 100% sure if we did this correctly or it's the best statistical analysis. So we had a plan also to call a tool to make sure that this is the proper statistical analysis that we should be doing. But it's pretty big size, again, depending on how many groups of handholds you have. So if you just have like one handhold versus another, that 539 per group is a lot easier to achieve in the ER, in a busy ER, than like if you have like 10 different handholds and 539 per group, then that's a lot of a lot of people that you'd have to recruit. And then, yeah, we do a comparison, and then we'd hopefully do different like regressions and things to control for the confounders that we'd identified before, so like the age of the child. Because one thing we had talked about too, like in terms of like age of the child, and like even if you think like 2 handhold versus 1 handhold, like if you have like a 1-month-old baby, they're almost always held with 2 hands, right? Like in my mind, like you're so careful when you're holding a 1-month-old baby versus like, and then I think as they get older, like you might be able to hold the baby like with 1 hand, but then when they get into more of that like 1.5, 2-year-old range, they might be so heavy that again, you're always holding them with 2 hands. You know what I mean? So then they're being, like both the older ones and the younger ones are being held with 2 hands, but for different reasons. And so I think you have to be careful, like again, with these like different developmental differences between the age groups and like why you're holding them a certain way. So a little bit of a like difficult question how to get at exactly which hold is causing more dropping. I don't know, we found it kind of a difficult question to grapple with. I don't know if you guys have things to add.
You summed it up quite well.
Did you guys have a way of addressing like, no, I've never held one child one way only? Like you,
Yeah.
you
So we
were
did talk
it's
about
like how do you?
that one of the questions on the survey would be, how do you most commonly hold your child? And then,
5, 1, 3.
yeah, and then like they would pick one. And then like, has your child ever been dropped? And if they said yes, then what position were you holding your child when they were being dropped? So that you can kind of get a sense.
Just to clarify, like, I understand why you guys didn't want to do the cross-sectional survey on the telephone, but like, your study ends up being kind of a cross-sectional study of the emergency room visits? Or,
So the idea with like
I
our
guess so,
cohort
yeah.
design is
Okay.
Because we're not really following them, so that it's
Yeah.
not truly like a cohort.
It's a retrospective.
Or a retrospective cohort, I guess is how we're thinking of it. Like over the past year, how often have you been dropped?
But in this semester.
but in a single, like, measure?
Yeah.
So like, why the emerge as opposed to like primary pediatric
Because
clinics?
people probably not gonna show up to primary pediatric, like, everyone's gonna show up to the emerge if they need to come to the emerge. We're not saying come to the emerge because you dropped your kid, you're saying come to the emerge because they're brought to the ledge or something, and then seeing that they dropped their kid.
Yeah.
People who drop their kids necessarily, unless there's something wrong, like, they think they're wrong, are not gonna go to primary care.
But, so is your
I
outcome,
think, yeah, I
is your
get what
outcome
I was gonna say,
saying
well,
that
maybe
the
check to be
child
agreed.
fell on the survey, or is your outcome like them having a fall in emerge?
No, it's not.
I get what you're saying, like you could do it in primary care
Yeah.
setting, like because, yeah, we're capturing people who haven't been dropped potentially too, right? And so
Or haven't.
I think we decided on the ER, like in my mind, more for like a ease point of
Okay,
view and to
yeah.
get like an adequate sample size versus like a primary care clinic, you might have to like have multiple clinics and like training with multiple people in order to get enough kids enrolled.
So I just have a question of it. I misunderstood, or maybe, let me just say, my understanding was that this is gonna be a prospective study, not a retrospective study. But now in this discussion,
Can be any way to design it.
but I think from my understanding, from what you guys have talked about, it's gonna be prospective. Or are you gonna do it retrospective? And if you're gonna do retrospective, what would be one of the biggest problems with that? Recall bias.
Yeah, recall
Yeah,
bias.
it's gonna be very difficult. But I think if you did it perspective, which was my understanding from when you presented, I think that's ideal.
Yeah, we talked about prospective too, but again, like how short of like having families like followed around, or do you just like have them report whenever their child is dropped? Like do you have them call when their child is dropped and
Nope,
say
so
like
it's
we
gonna
were?
be there in the ER, right?
Yeah,
So, and I agree that there's gonna be a cohort that you're gonna miss through the primary care clinics, but we'll have to accept that flaw and live with it and then factor it in the analysis, but to collect the data, you can go through ER. You had calculated your sample size, and then you were concerned, well, that might be too big, and we may not get this number. But I think if the question is important, which it is, because otherwise you wouldn't have asked it, then I say, can you think of a way around it? So don't think just our children's ER, right? This is the way you've designed the study, the way you've thought about your questionnaire and how you're going to approach the families or the parents or whoever brought the child in. It's beautiful and detailed, but yet reproducible. And I don't think you'll have difficulties training someone else to be able to be the person in ER when that call happens, right? So you can actually potentially collaborate with multi-centers so that you can, in a reasonable period of time, and you can calculate that as well based on a retrospective look at the number of children who comes into Montreal Children's because of a fall, right? You can quickly do that, and in a lot of the studies that I do, for example, I wanted to look at the incidence of corner-truncal anomalies of the heart. Those are epigenetically modified type of congenital heart disease. It's not a common variety heart disease. The origin of those is a neural crystopathy. So when people look in the literature, they just say, well, the incidence of congenital heart disease is 6 per 1,000. That doesn't help me. So, but to be able to kind of think of what is the sample size I'm going to have to look at, I had to go back and say, let me ask different children's hospitals that have a specific devoted one center for children's for cardiac problems, and let's look. So this way I was able to say, well, this is the sample size. But anyway, so I think there is a way around it. And I think doing multi-center would give you more power in your ability to actually come with some concrete conclusions to say holding this position is associated with a high risk of fall.
So, let's move on one more time. I will make a comment still. So,
We're actually okay for time, we was supposed to finish at 11.
at 11?
Yeah,
Oh, I thought it was 10.
no, it's 11,
Oh, okay.
we're good.
I'm glad my 10:15 meeting got canceled.
That's the only one we're grouping.
So you highlighted how challenging this particular type of a project would be in terms of the nature of the outcome, which is associated with some fairly negative stigma. So sometimes, and then you considered the case control design and said that you would miss too many, I think is what I understood, right? So, however, sometimes when you're dealing with an outcome that is difficult, you may want to decide what portion of the outcome is actually the one that you care about. So there's likely a lot of children that are dropped just because of life, and most of them do perfectly fine. The ones that are dropped and actually need to come to the emergency department to be assessed are probably more effective. And those might be the ones where you might want to actually highlight how did they fall, how are they dropped, and is there something in particular with that hold that is particularly problematic. So, because one of the issues sometimes with things like this is that there's so much noise that getting the signal is difficult. So that you may want to restrict what you actually consider to be the signal of interest so that you can wash out a bit of the noise.
Yeah, it was like difficult, like you
It's a
said,
tough
to like
question.
hone it down, and we're like, okay, well, do we just like make it very like by like two groups, like this hold and this hold, like one hand versus two hand, but then I think you're missing like how exactly were they being held? There's so many ways you can hold a child.
That's where your
Yeah.
picture kind of thing in your questionnaire, and when you're interviewing them, comes in handy. So I think you did a good job thinking about how you're gonna approach it. And you did address the fact that there is a stigma associated with it, and you said we have to come with a very sensitive approach to asking these things. I actually went through it as a parent too. So, we didn't drop the tribe, but anyway, so it's, yeah, Leonardo was doing a study similar to this one. They threw a question in, and I participated, I asked my wife to participate, but it's important, and I never felt, I just sat as a bystander, as an observer. I felt it was done very, very well, and I don't think my wife felt threatened in any way. So there are ways around it. You have to do it. I mean, if it was an easy question, anybody can do it, right? But you do the difficult ones. But that's, I really like how you guys approached a very difficult question to come up with some good, concrete, scientific ways of asking it. But if we shy away from every scientific good question just because of there's stigma associated with it, we'll never be able to get far in anything we do, right? Good job.
And you did a very nice job of thinking about variables and how to control it. One thing that I thought might have would be important with this particular question is the cultural aspects of holding. You know, if you think of the Inuit who hold their babies in the Mounties, that's a very different thing from, you don't see a lot of Mounties in River Heights. So,
Well,
that's
too,
another.
there's like so many like contraptions for holding now too, and do you
Yeah.
like use those, like the wraps that people have for like holding their baby, or
Yeah.
like the like carriers, like do you include that? I feel like they're less likely to fall from that, but yeah.
Or like a
Have you ever tried to put a child into one of those
Yeah, but
things?
putting, yeah, and
It's
I've read like
They fall
articles,
en route.
I've read articles too where, like, you know how there's all the like mom blogs online, and like there's been people I've seen posting before who are like actually get annoyed when they're trying to put their child in like their wrap, and some random stranger tries to help them because like they're used to doing it on their own, and then the stranger actually doesn't have any idea like how they normally do it, and it actually causes them to be more distressed than if they were just doing it on their own.
Okay. Last but not least.
Alright. So our topic was, does saline locking an IV compared to TKVO prolong the life of an IV? And then in brackets, saline locking is to reduce the risk of potential IV tubing wrapped around the baby. So we designed a randomized clinical trial for this. So just to go through the basics, our PICO question would be population is pediatric patients, kind of age infant to 17, require a peripheral IV for medical care who are admitted to hospital. And for this, we said that we would want the IV to be in the arm, like antecubital or distal. I'll go through all of our, we have a lot of exclusion criteria, but I'll go through them after. Our intervention is saline locking IV compared to running a TKVO. Outcomes that we would be looking for, the primary would be length of IV in hours, so how long it stayed in, and we have to stratify that between ones that went interstitial or were lost versus ones that were ordered out by a physician. And then secondary outcomes, we would look at infection and then interstitial infiltration and any sort of adverse outcomes of the IV. So our alternative hypothesis would be that saline locking IV has a prolonging effect on IV life when compared to running TKVO. And then null hypothesis would be that there is no difference between saline locking an IV and running a TKO. So inclusion criteria would be and then pediatric patients who require an IV for medical care that are admitted to the hospital. And then we had a lot of exclusion criteria because there's lots of IVs that you're not going to be able to saline lock. So a lot of people with complex medical care. We said probably most of your PICU patients are not going to be eligible for the study. Anybody who's in shock, anyone who's going to the OR because they tend to run fluids when they're NPO as well as in the OR, any of your DKA patients, anybody who has a central line, anyone who's getting ongoing fluids or TPN. So basically anyone who has a contraindication to having their IV saline locked would be excluded from this study. We should go over the actual design if you want.
Okay, so it will be a randomized double-blind. The way of randomizing, we will use a computerized block-based, and we'll divide them into A or B. The way of blinding, because we have unlimited resources, we'll contact one of the companies to make an IV pump that shows like everyone is like pumping the KOB, but actually some of them is locked only. Continue.
Yeah, keep going.
The p-value we are targeting is a 0.05 with a power of 80%. We measured the sample size using the T-score schedule, and we are expecting like we need almost 390, but we will add to them almost 20% because of dropout and other things. So we will like calculate almost like 480 patients.
Yeah, sure. So in terms of looking at our results, as I said, we looked at the length of IV rate, life, as well as infection and other complications of IVs. So we'd want to stratify based on age because an IV in an infant is very different from an IV in a 17-year-old. Stratified based on sex, number of days admitted, and then also stratifying whether the IV was actually lost or whether it was purposefully removed. In terms of just circling back to the kind of design, we would want the IVs put in by a specialized team to kind of like minimize any sort of variation there. Yeah, exactly. And they would be on call, again, because we have unlimited resources, be on call 24/7 and be able to put in an IV at any time. And then we would have uniform protection of the IVs kind of as per hospital best practices. So the young kids would get the arm board, the older kids would probably not get an arm board, and just kind of continue as how they normally protect IVs. In terms of statistics, again, because we have so much money, we're going to hire a statistician to help us. But to detect a difference, we said we would do a one-tailed t-test just to see if that checked for superiority or not. That's it.
I have a question. Why did you choose to do a one-tail t-test instead of two-tail? Because you're not positive whether TKBO is better.
Yeah, so we just, because our alternative hypothesis was that it would prolong, so then it would just be one tail. If we said it was
So which one
different,
would
then it would, that the IV saline lock.
Okay, but then you would kind of miss it if it was the other way around.
Mhm.
The TKBO prolongs it.
So
So your
you
power
could make-
package is also one tail then.
Yeah.
I was just curious why you chose like the blinding approach. I would wonder like maybe you could see a difference in terms of like prolongation of the IV life, but I wonder if it would be important to balance that against like the ability of the child to like go for walks unencumbered or like the like tango rate. And so I think like one of the benefits of saline lock is that you can. Yeah, so I'm just not sure why you would like blind it and what purpose that would serve.
So I think blinding it would give you like a true, doesn't make a difference on the life, and then, you know, you could like, if you just did this study and got that information, then you could look at kind of the other differences if you just straight up saline locked it, like the rates of entanglement and such like that. So this would give you, I don't think it's necessary, but because we decided we had unlimited resources and maybe like it's a little bit like pie in the sky to think that you could do this, but it would probably give you the most true difference in terms of whether the TKO versus IV saline lock, like whether the difference is truly from running the TKO fluids or not.
Like, how would you even line? Saline lock just means that you're gonna detach it where you want, right? And then if you detach it, you know that you're saline. No, they have this new pump and they're gonna vent.
Yes.
What's the TKBO?
I had a question, do you think you could do like a crossover trial where kids, like after their IV failed, they got a different intervention so that they acted as their own controls?
Mm-hmm. Yeah, we talked about that a little bit, and I think that would be like a very reasonable thing to do because we talked about if they lose their IV, do we consider that the end or not?
Or a new patient, or we consider them as a new patient.
And so,
I think you'd almost have to do that because you can't guarantee that. I mean, often when we lose an IV, we then say, well, do they still need it? We might say no. So you might, if you didn't have a crossover, then that was be out. If they didn't have that.
But that one's hard. A lot of the kids that lose their IVs, their TKBO is because, not TKBO, because they like saline locked it. They went to play and they went to
Yeah.
do other things.
And I also wonder, I like the blinding for the purpose of like, do IVs come out, but I think one of the important things is to look at the overall, like the benefits of being able to leave your room or to go play, and our ability to put back in IVs is decently good. So if it
improves their quality of life while they're in hospital. And like thinking in that sense, you could totally do this as a like multi-step where you do this and with all of your money and fancy gadgets.
Yeah, like if
And
the
then-
same, yeah, sorry.
And then like the second part would be just straight up saline locking and kind of looking more at some of the, you know, qualitative stuff and entanglement and stuff like that.
Just gonna say, like, I wonder too if the saline lock, if it like comes out more often, not because of the fluid itself, but because they're like playing and they knock it or whatever, and so then you might miss that difference, but you would determine if like it's truly just the fluid that's causing it to stay in better.
So kind of, I guess it depends what your
What you're
question
looking
is.
at,
So
yeah.
like, because we were looking, does the fluid actually keep it open? Controlling for everything else is probably the best way to look at it, but it's probably not gonna be clinically
Yeah, it's not
significant,
as
because you're
like,
totally right, like the second that they get IV
Practice.
saline locked, they're like off the ward, gone. Like, they're able to do stuff, right, so.
Yeah, so there's, I guess, a few questions, because I was looking at your question here, and it looks like it's a two-part question, right? So there's the issue of like the TKBO infusion prolonging IV life, which you addressed with your fancy pump that doesn't pump, I guess. But then there's also the second part, which is reducing the potential of IV tubing getting wrapped around the baby, which then your fancy pump that doesn't pump then actually makes that risk higher.
Yeah, it's just, they'd all be the same, you wouldn't have a comparison group.
Right, but I guess, so that's where it becomes important to kind of define which part of the question is most important. Is it the safety aspect? Because then your design might be
very flawed.
problematic. Or is it the prolongation of life, at which point your design would be perfect for answering that particular question? So, and then the other issue is, I was just listening to your exclusion criteria. If I understood them correctly, your exclusion criteria were the ones that would prevent you from becoming saline locked.
Yeah.
Right. But so you wouldn't be you wouldn't enroll someone who you couldn't saline lock. So what would actually be exclusion criteria of people who would qualify for the study? Do you understand what I'm saying?
Yeah,
Refuse the patient
Yeah.
or the parents, that's for sure. Intentionally removing the IV line.
like the child
Yeah.
intentionally.
We did not think it's that way.
Yeah, I guess like anybody who, if you think that they're, like the length of time that they're going to need an IV is going to be like very long, and that you're kind of from admission already starting to plan like central access and stuff like that, that might not be, they might need an IV at time and kind of be included in terms of that, but it might not be appropriate to enroll them if you're already like on day 1 or 2 of admission thinking about like that they're gonna need like a PIC or a central line. That might be somebody that you would exclude. Someone who like was a very difficult poke, who maybe they got a peripheral but it required like several people that are super specialized on-call team had difficulty getting the IV, you had to call for like an anesthesia consult or something like that, would also probably be someone that you might want to exclude.
And with that, those people though, like, those are the people we're doing the study for. 'Cause
Yeah.
those are the ones who currently
Yeah, I know.
often don't get saline locked because they're
We're like, we
people
gotta keep
worried
that
about
IV
the
open, yeah.
So excluding them
Yeah.
limits your ability to generalize.
Yeah, and we said, like, I guess we kind of did say, like, we said it more in the inclusion, but in terms of peripheral IVs, like, we excluded kind of non-arm sites, just because I think it's not as easy to, like, standardly protect a foot IV or, like, a scalp IV versus, it's, you know, the arms, it's fairly easy to put on an arm board, especially for the little ones to protect it.
I would say, so thank you, that was very nice. So you get a question, you're given a half hour to think about it, you're given a half hour to come up with all these things. That's not easy for any of you guys, right? The comment I wanted to make, that I think that's important for everybody, is that when you think about a question or a hypothesis, you always have to think truly long and hard about it, because that's the most critical part of doing any research. I'd like you to think ahead when you're thinking about the hypothesis of what the outcome might be. I'm not saying that you're going to create a false impression with the research you're doing, give me some false data to say to me, this is the way we're going to do it. But rather think that at the end of the day, you're going to produce some evidence-informed practice or change of practice, right? So when let's say, somebody, one of the bigwigs in the hospital say to you, we want you to design a study that looks at saline, locking, an IV, da-da-da-da-da, right? And policymakers and people who may ask you to do that may not think of things the way you think of them. So they may ask you to do something that's way too much. So you can break down the question into its components and think, how might I approach answering one at a time? Okay? And don't try to piggyback on things unless it is appropriate. Okay? A follow-up study, crossover study, those kinds of things, you can think about them. It's appropriate, we do it all the time. But you have to think, is it appropriate or not? But your primary goal has to be focused on, so in this question, to me, I would say, I'd like to focus on answering either the first part of the question or the second part of the question. Because if you try to do both, you're going to do things that truly, that are not going to let you answer the question the proper way. So focus on one aspect of it, and then sink your teeth into it exactly the way you did, then designing it. And like I said, I always like to think of the hypothesis as something that you're not doing it just because, but you really want to answer a question that your colleagues can't answer for you, and the literature can't answer for you. Right? So I would also include in what I would do and what I present to people is I say, well, as an administrator, you gave us this question. We're only going to address the first part, which is, does a TK, does a saline lock reduce the expectancy of patency of IV as opposed to TKO? And that's all I'm going to address now. And then, like I said, you can go ahead and design the study the way you like and answer it the way